My topic today is related to sedation. Now, if you look at sedation, there are different aspects to it. First is in terms of the depth of sedation or the levels of sedation. You have minimal, moderate, and deep sedation. And then you can achieve these different levels of sedation through many routes, which are classified as oral and parenteral. And when it comes to ECC management, we all know that when we are using sedation, there needs to be some idea about the duration of the procedure, the invasiveness of the procedure, and most importantly, whenever we are going to recommend a type of sedation, you need to be thorough about, you need to have a proper assessment of the behavior of the child. So when we say sedation choices in the management of early childhood caries, we're not just referring to drugs or drug dosing alone. We have to understand that we are talking about a multitude of factors which need to be considered, and each factor plays a very significant role in determining the type of sedation that you would need for the management of early childhood caries. Now, let's brush up some basics before we go ahead. We all know that sedation is a continuum, meaning that you just cannot say sedation is one particular point. All right, sedation is a continuum. A sedation that has propensity to induce minimal or moderate sedation when uncontrolled can also lead to deep sedation. Now, the best part of this table that was given by the American Society of Anesthesiologists is this dotted line that you see in between. Now, this dotted line represents sedation. It gives a clear distinction between the sedation that can be administered by the practitioner himself and the sedation that requires the support of a specialist. So, if you look at this particular flow chart, you will understand that when it comes to minimal or moderate sedation, you will notice that the patient response is still normal to purposeful, and the patient is able to maintain his own airway, so you don't require any special airway interventions over here. And it's definitely a perfect choice when it comes to management of early childhood caries in outpatient settings. Now, not all children might be maybe great candidates for minimal or moderate sedation alone. You probably require a more deeper level of sedation or general anesthesia in case in some children in order to manage their ECC burden. So in such a situation, it's always necessary that you always do deep sedation under the supervision of an anesthetist and in an appropriate specialist center. Now, just let's have a quick overview of the different types of sedation that we all know about. Now, I just want to give you a small reminder that this is not a 100% sedation lecture. This lecture is more about making the right choice of sedation while managing early childhood caries. So I'm going to give you a very quick overview on the different types of sedation that we use. The most commonly used being oral sedation. We all know that the myriad of drugs that are available for oral sedation, midazolam of course being the most commonly used drug. And we also know that a lot of practitioners have tried combining midazolam with other types of oral sedatives as well. Especially you will notice that midazolam has been combined with hydroxyzine, with ketamine, with meperidine, also called as pethidine in India. So these are all the very commonly used oral sedatives. Now, one lacuna that we face in many developing countries is that the sedatives are not available very freely in the in the market. So most of the times we end up converting injection solutions with an appropriate masking agent, which in our country could be a paracetamol syrup, or Kool-Aid, which is used very commonly in developed countries, or some kind of a sweetening agent which will enable better consumption of the drug by the patient. We all know the pros and cons of oral sedation. Oral sedation is very inexpensive. It's very easy to administer. You don't require any kind of a special training, for your assistant or for the doctor to administer oral sedation. It can be even the drug can be provided even by. The drug can also be provided by the parent themselves. It is less objectionable. Now, like it's very easily accepted by the parents. There's no pre-procedural anxiety. But the greatest problem with oral sedation is its unpredictable nature and the prolonged waiting time, which is attributed to the first pass metabolism that may vary from individual to individual. And most sedatives undergo extensive metabolism in the gut, which also makes it very, very unpredictable. The second thing being that in very uncooperative children who are very definitely negative children, you might find that the child may not accept the drug, the child may spit out. And of course, a lacunae with any kind of with every bolus sedation like oral sedation or intranasal sedation is that it's very, very difficult to reverse the actions of oral sedation. And the next common type of sedation that's used worldwide is your inhalation sedation. A very good thing about inhalation sedation is that even at the highest concentration, when delivered by an approved sedation equipment, you will notice that even at the highest concentration of nitrous oxide, you can only produce minimal or moderate sedation. There's no way that you can induce deep sedation. Deep sedation cannot happen in case of nitrous oxide inhalation sedation, which makes it one of the most safest type of sedation when used alone in the OP settings. But one caveat when it comes to nitrous oxide inhalation sedation is that you require some kind of cooperation from your patient to accept the nasal hood. Now, without that small degree of cooperation, your noise, the delivery of your nitrous oxide inhalation sedation may not be really great. So many practitioners tend to make use of other modalities to make the nasal hood more acceptable in children. Now, as far as the advantages are concerned, we all know that this has most rapid onset. Peak effects will develop very, very rapidly. It has a flexible duration of action, and that's one of the reasons. It's also called as relative analgesia. You can titrate and alter the depth of sedation from patient depending on the procedural need, depending on the patient. So which makes relative analgesia with nitrous oxide inhalation sedation a go-to procedure. And of course, no doubts we all know that it has a faster discharge. You can bank on the faster discharge ability of the noise as well. The other types of sedation include intranasal sedation. Now, this is especially reserved for children who may not be great candidates for oral sedation, who may refuse taking drugs orally. So in those conditions, probably intranasal sedation is going to be a good choice. And the most commonly used drugs include midazolam, ketamine, and dexmed. And the greater benefits of intranasal sedation is that it is one of the most painless method of parenteral sedation. After inhalation sedation, it's one of the most painless method of parenteral sedation, meaning it's a sedation that can actually bypass the first pass metabolism without being very invasive like your intramuscular sedation or your intravenous sedation. And it has greater bioavailability. When we were talking about oral sedation, we said how the drugs which when consumed orally can undergo extensive metabolism in the gut. So intranasal sedation has the greatest advantage of providing relatively greater bioavailability without being very invasive as well. But the problem is that the procedure by itself can provoke some anxiety, and of course the mucosal health. When the child is having significant respiratory tract infections, it can induce some amount of anxiety. It might respiratory tract infections, especially upper respiratory tract infections, can interfere with the absorption of intranasal sedatives. And coming last to intravenous sedation, which is more commonly used in young children for its potential to induce deeper levels of sedation. And most of the times the drugs are the choice of the anesthetist, depending on the duration of the procedure. You can choose the drug. And as mentioned here, the most prominent features of intravenous sedation include its rapid onset, the ability to control the dose. Now, this is a fantastic thing about intravenous sedation, is that you can titrate the dose depending on depending on the symptoms, or depending on the symptoms of sedation exhibited by the patient, and depending on the need, or depending on the need for depending on the amount of movement reduction that you require during the procedure. And it of course produces deeper sedation when minimal or moderate sedation is not really effective. It gives you a more deeper plane of sedation where a lot of procedures can be accomplished because the resistance and the response to stimuli obviously becomes lesser. But The perils of deeper sedation include that it puts a patient at a greater risk because of the loss of protective reflexes, which begs the use of begs the ensure which for which we definitely need the presence of skilled personnel, intensive monitoring, and the center where we are conducting intravenous sedation, where we are treating patients under intravenous sedation, should be well developed to manage any kind of emergencies that may arise during a session of deep sedation. Now, that was a brief overview about all the different types of sedation. Now, if you want to understand in detail how we select patients and how do we ensure that the sedation procedures can be safely administered to children, I suggest that you look into you take a screenshot of this QR code and check this particular lecture that I've given exclusively on selective candidates for sedation procedures, both deep and moderate sedation procedures. But as I said, this lecture is about making the right choices in the management of ECC. Now, although numerous systematic reviews are present in the field of sedation, we still find that there is a great lacunae or caveat in that we do not still have enough evidence-based recommendations, or procedure-specific evidence-based recommendations are lacking when it comes to sedation dentistry. So what we decided to do in this presentation is to create a decision tree. Now, by means of this decision tree, the practitioner can actually select the right type of sedation, and we are going to explore the different factors that can actually help you in making the right choice. And for the purpose of making this decision tree more simple, we are going to classify the procedures that we do to manage early childhood caries into three categories. Let's say we have minimally invasive or short duration procedures which are going to last only for 5 to 10 minutes, like your SDF application, fluoride application, or those emergency situations where you just want to remove 1 or 2 teeth, or quickly paste a Hall's crown. So these are all come under short duration or minimally invasive procedures. And then you have procedures of moderate duration, like may not exceed more than 30 minutes. Many times you find patients walking out with pain related to one single tooth, which would be, where the pain would be taken care of by just doing a proper endodontic treatment for a single tooth. Or there may be children who require multiple restorations, wherein the total duration of treatment may not exceed 30 to 40 minutes. And of course, on the other end of spectrum, you have children who require extensive procedures, multiple procedures involving many teeth, typical cases that we end up doing under general anesthesia. So here starts a decision tree. So the moment you decide if sedation is required, whether sedation is required or not, one of the best resources to bank on is the AAPD sedation record. I've given the link for downloading the sedation record at the footnote of the slide. Most patients who require sedation fall within these 4 categories. Either they are fearful and anxious, and all our behavioral guidance techniques have failed in these children. Patient is unable to cooperate because of lack of psychological or emotional maturity, because of which the patient lacks cooperative ability. And to protect, you may have very cooperative children, and you want to ensure that they have a good experience, all right, a good experience during dental treatment, making protecting developing psych also an important indication for sedation. And of course, in children who are at medical risk, in order to reduce patients' medical risk, we do use sedation at times. So if any one of these indications are satisfied, all right, then yes, you go to the next step of the decision tree. Now here, you need to ask yourself or check the patient to find out if the child is medically compromised by any way or has contraindications to any specific sedation methods. Now, the 3 main things that can help you in diagnosing anything, diagnosing factors related to this include the ASA classification of physical status. You just have to categorize children whether they are healthy or not healthy. Any child beyond ASA 2 is not a great candidate for sedation in office. The next criteria includes, taking a general medical history. Now, whether for the presence of allergies, medications, any other diseases that may influence the delivery of sedation in an outpatient setting, and the presence of sleep disordered breathing or associated symptoms, relevant to birth, family, or social history. And most importantly, with the increased number of obstructive sleep apnea related risk factors that we tend to see on a day-to-day basis, it's always good if to do an airway assessment in order to understand whether these children are good candidates for in-office sedation or not. Now, the moment you see a red flag in any of these findings, all right, if you find that these children are perfectly okay, no, they are not medically compromised, they don't have any specific concentration, you can move on to the next decision, the next step of the decision tree. But if you do find that there are some red flags, all right, the child may require a consult with your pediatrician or anesthesiologist, and from there, any of these three decisions may occur. Probably the pediatrician or the anesthetist may say, let's avoid sedation and try routine behavior management techniques itself, or let us consider general anesthesia in a tertiary care center, or the pediatrician or the anesthetist may also say like that the red flag is not a very potential influencing factor, like you can go ahead with routine sedation, in-office sedation itself. Now, the next question that you'll have to ask is regarding the anticipated level of cooperation. Okay, now what is necessary over here is to assess the behavior of the child. Is the child cooperative? Is the child cooperative but a little anxious, like Frankel's positive type of children? Is the child very uncooperative, extremely anxious, or does the child lack cooperative ability? Now, this is a very simple but classification of behavior of children who may enter into the dental clinic, because as soon as the child steps into the dental clinic, we are mentally making this classification whether we like it or not. And let's break down into individual subheadings. If a child is very cooperative, the reason why you're doing sedation for this child is basically because you want to protect their developing psyche. So in that situation, I would say basic behavior guidance and inhalation sedation works perfectly well. Just guide the child with proper candidates for sedation. You will notice that they cooperate really well, and nitrous oxide inhalation sedation is only going to add to making this experience a great. Ensure that you're coupling it with the right type of audio visual aids. I'm going to skip this video and move on to the next type of SAT category of patients. These are patients who are cooperative but have some anxiety, as we say, Frankel's positive type of children. Okay, so in these children, once again, the reason why you're administering sedation is because you want to protect their developing psyche, and that's the main reason why you are administering sedation. Some amount of behavior guidance and in order to help them accept the nasal hood is going to make the procedure really perfect, really good in these children. And oral sedation, we've seen that some children benefit from oral sedation as well in this subcategory. Like as in this child, the child was actually cooperative, but he was a little anxious in the beginning. But with proper behavior management and nitrous oxide inhalation sedation and with good rubber dam isolation, you see that most of these children in the second category can be very, very easily managed. And as I said, okay, behavior guidance ensures that the future appointments of these children are also well maintained, and it gives a pleasant experience to these children. And I'm just going to skip and move forward. Okay, now the third category includes children who are very uncooperative, extremely anxious, and the reason why you're doing sedation is probably because your basic behavior guidance techniques have all failed in these children. Now here, when it comes to delivery of treatment for the management of ECC, now, oral sedation or intranasal sedation can be effective for the first category of treatment procedures that we discussed. That is, in case of short duration procedures or minimally invasive procedures, we find that oral sedation or intranasal sedation works very perfectly well, actually. In fact, when coupled with basic behavior guidance techniques, you will notice that some of these children actually become a little better during the second appointment, and thereafter, from the second appointment onwards, you would even notice that the children become, there's no need for even sedation in the second or the third appointments. But the greatest problem arises when these children present with emergency problems, cutting us the much needed time for behavior shaping. So when the procedures are extensive, of course you would bank on intravenous sedation and general anesthesia. And this is once a child who was very anxious, uncooperative, But all that he needed was his endodontic treatment of a single tooth, which was carious and had a traumatic incident resulting in a periapical sinus. So we had to use intranasal sedation because the total duration of the procedure was going to be within 30 minutes. We decided that intranasal dexmet would be a good choice of treatment for this child. So you notice that after dexmet administration, we were able to do the root canal treatment. This child still needed some amount of restraint in order to for faster delivery of treatment. So that's exactly what you can do with intranasal sedation. It gives you a short burst of cooperation, and you have to very quickly finish your treatment within that duration. It gives you a very good moderate sedation that you need to really use. And of course, in some children who require extensive procedures, even in uncooperative children, sometimes intranasal sedation coupled with noise can actually work. In some of these children, intranasal sedation can actually calm them down and make them more amenable for behavior guidance. Thereafter, with proper guidance, you would be able to guide these. We would be able to guide these children properly, and yes, we were able to do extensive treatment in this child with intranasal sedation and noise. The last category of children are those children who lack cooperative ability. Now they lack cooperative ability because of lack of psychological or emotional maturity, and in those conditions, once again, intranasal sedation can be a valuable aid in providing short bursts of cooperation that can be used for minimally invasive or short duration procedures. As in this child, we noticed that when she had a pain related to a single tooth, intranasal sedation just gave us the least amount of time, a window, the smallest window that was available to do very minimally invasive treatments. We could apply SDF, we went on to extract one teeth. But again, many times we notice that by around the time that this sedation weans off the child, you may have to hurry up with the procedure, and you may have to go ahead, restrain the child, and probably do one of these last steps. So I'm going to skip this video. This is just another special child for whom intranasal sedation worked wonders. So I'm going to go to the next question. Now, the next question that you'll have to ask is your setting, that is your center equipped for the chosen sedation method? Like, have you undergone good training? Have your assistants undergone good training? Do you have enough personnel to provide good dental care? Or do you have the right type of equipment for any emergency management of these children? If yes, proceed with the chosen sedation method. No, it's better that you reevaluate and choose a different sedation method. This particular document on the guidelines for monitoring and management gives an excellent summary of all factors that are necessary before you on how your center has to be equipped for moderate and deep sedation. The last factor that you have to consider, but often missed, includes the parental preferences. Is the parent okay with non-invasive methods? Do they have preference for only selected methods, or are they totally against any kind of sedation? Now, based on that, you may want to decide on the type of sedation that you would want to provide. So to conclude, when it comes to choosing the right type of sedation in the management of ECC, it's just not about taking the right drug that you have in your cabinet and using it on the child. It's about considering all these factors, and when you consider all these factors, there are less chances for failure, and your sedation procedure is going to be perfect when it comes to management of ECC. I know we are exceeding our time limit, so if you have any questions, please shoot it on my Instagram ID. That's my Instagram ID, the Dental Academy, or on my Facebook page, and I'll be glad to answer your doubts, where you can personally message me or mail me at thedental@gmail.com. Thank you very much once again, Team CECCRe, for this wonderful opportunity.